on. It's really nice to be here. There's some familiar faces, some faces I haven't seen in a while, so really nice to be here. There's a lot of speakers throughout the weekend that I really admire and I think are pushing the profession into the right direction, so it's really nice to be here. I'm going to talk just a little bit about my own PhD at the start, because I've only really just started it and I don't have lots of data to show you, so I'd be struggling to have an hour presentation based on that. I am going to talk about active self-management. So if this conference is truly to do with wellness and prevention, then I feel that active self-management is a real key and kind of almost ignored topic that I feel we should have more of in our education and more of in our profession. Unlike most of my esteemed colleagues that have been talking this weekend, most of you probably don't know who I am, so before we dive into the research and keep it quite light, I thought I would tell some of you guys who I am and why I've come to talk about self-management and physical activity and all of these kind of things. My journey to become a chiropractor is a bit unusual. So a lot of people maybe have had some sort of chiropractic treatment in their life, or they were part of a chiropractic family. They knew something about chiropractic and became a chiropractor, but that was not the case with me. I used to be a personal trainer and I was a physiologist for Nuffield hospitals. And I used to actually talk at some health and fitness conventions. And you may have heard of a gentleman called Paul Chek. He's not as well known as he used to be, but he was fairly well known in the 90s. He was kind of famous, if you like, for introducing the core stability concept and Swiss balls, especially, or stability balls as you may know them, into gyms. And I was actually on stage with him. So if you look at me, you might think I'm giving you a bit of a funny look at times, because my right eye is a glass eye. So sometimes it doesn't move quite as well as my normal eye. And the relevance of that is that I was on stage with Paul Chek and he looked at my eye, and I'm really bad at accents, but he said to me, "Paul, what's up with your eye?" He's got a San Diego accent, if that's anything like a San Diego accent. He said, "What's up with your eye, Paul?" And I said, "Oh, it's a glass eye, don't worry about it." And he said, "Do you know that that's going to make you subluxated in your atlas?" And I was like, "What?" And he says, "Your atlas is subluxated. You've only got one eye. It's going to pull it off to one side." And that was the kind of message I was told. I was also told that would have considerable negative health consequences for me as I got older. So I was, if you listened to Jeremy's talk yesterday, Jeremy's voice, by the way, I was listening to him on YouTube on the way down. I had the earphones in as I was driving and I was nearly falling asleep. Not that it wasn't interesting, but his voice is like velvet, so you've kind of got my scratchy Northern Irish tones, but Jeremy had such a lovely voice. I was struggling to sleep last night. It was so hot in the room, so I put on Jeremy's voice and I was like, Nasibo is really nice. But anyway, bit of a tangent. So that communication to me was perhaps not the best advice to give me at the time, but being the character that I am, I really wanted to learn as much as I could about this subluxation of the atlas and chiropractic, and I was working full-time at the time, so there was no chance of me really becoming a chiropractor. But at McCambridge College, they did a part-time course, which was a little bit longer, but you could go up there at weekends. So I thought that'd be the best way for me to learn all about this and kind of fix this problem. And I'll tell you something, sure enough, for the first year I was at college, for the first year anyway, there was students putting their hands on my neck. And in the morning, my atlas might be out a bit to the right. 5 minutes later, it was off to the left. Some days it was upside down. And those were the really bad days. I was really like grumpy or pissed off on those days. So that was a bit of a concern, I thought. But as I evolved through the course, as I kind of learnt some critical thinking skills, as I became more interested in research, I actually got a lot of comfort from that. I got a lot of comfort from the kind of challenge to the sort of pathokinesiological models, the structural models, the idea of alignment and nerve interference, and the kind of challenge to this through research. I think the more people dig into research, they tend to become more uncertain, especially when you're talking about chronic pain. The research around what we should do kind of leads to a very uncertain evidence base and a very uncertain treatment. And I know quite a lot of academics now, and they're all kind of screwed, really. They're all a little bit mental, if that's not the politically correct term. And I can understand that, because the deeper you dig into things, the more uncertain you become about things. So it's really all about how you deal with that uncertainty. But for me, I got a lot of comfort for it, because ultimately I had the choice between being screwed for the rest of my life or just being a little bit uncertain about things. So I was happy with the uncertainty. But that led me to want to learn a lot about research. So pretty much as soon as I finished my chiropractic master's, I really wanted to do a PhD. But I didn't have much research experience beyond what I did in my thesis, which really wasn't that good, Adrian will tell you, at McCambridge College. So pretty much every 4 weeks or so, Adrian got an email and I was applying for another PhD, which I didn't get, and another PhD. So he must have been sick of me constantly asking for referral letters. So I needed to get a little bit of experience in research. So I did a little bit of work with King's College London. They've got a massive project called the HERON Network, which stands for Health Inequalities Research Network. And to cut a long story short, I helped create a physical activity program for young people with low-level mental health conditions. Initially, they just had a running club for them, which was a problem because none of them liked running. So I came up with a great idea of making it a little bit more creative and more playful and more social. And they thought that was an amazing idea. So that's been kind of evaluated for feasibility. And I've also created an app, a self-management app. It's not live yet, but it's actually undergoing some feasibility and evaluation tests with King's College London. And it's a self-management app for people with low back pain. So to create that app, I kind of needed to learn as much as I could about self-management. That was done, by the way, with a company I was working for called Results with Lucy. You probably haven't heard of Lucy Mecklenburg. Has anybody heard of her? Didn't think this would be her audience. Oh, Catherine's heard of her. Lucy Mecklenburg, yes. She's on the front page of OK Magazine at the minute, if anybody reads that journal. No? So she was on the UniWest Essex. She's a celebrity of sorts, and she's got a health and fitness website. She's got 250,000 subscribers to that a month. And it really amazed me working there. I was kind of like the ugly face behind the scenes of that company. So Lucy was there. She was delivering these programs. I introduced a bit more of a psychosocial flavor into some of the things that she did, but I was hidden. I was on camera once, and the cameraman told me I looked like a corpse on camera. So I was going to wear a bit of fake tan for today, but that didn't really happen. Beside everyone in Essex, by the way, is very, very brown or orange. So it's the truth. It's the truth. And being from Northern Ireland, you don't fit in very well there. So I wasn't allowed on camera, but I helped create a lot of the programs. And it's amazing because Lucy, to be fair now, she does know a bit more. But at the time, she didn't really know much about health and fitness. And I think this ties in with what Catherine was talking about yesterday, that the message really, it has some importance, but the delivery of the message is much, much more important. I could see how this lady who had really no interest at the time in health or fitness was influencing hundreds of thousands of women to be a bit more active, just by simply people resonating with her story a little bit. And as I think it was Jeremy said, the human brain loves stories. So I think as researchers, we really have to figure out how to kind of produce our information in ways that people actually can understand it and read it and leads to behavior change. Because the reality is that all these big things that we're talking about this weekend about public health and smoking and alcohol and physical activity, maybe eating more vegetables, stress management, this is not new. This has been going on since ancient Egypt. The doctors have been saying this since that time. And there's a very famous doctor who I've actually done a bit of work with before he was famous, Dr. Rangan Chatterjee, who you may know. He was in a BBC show called Doctor in the House. He's got best-selling books. He's very hot right now with podcasts. What's he saying? He's saying for people to manage their stress, to sleep a little bit more, to be a bit more active. This is not new information. He's just delivering in a way as a tall, attractive doctor, in a way as a GP that's got a little bit more credence and authority, that for some reason that's affecting people's behavior. Joe Wicks is the same, a personal trainer. He's got 3 of the top 10 best-selling books in the UK of all time. He's not doing anything different to what a normal personal trainer will do. Yet he's influencing so much behavior. So I think it's something that researchers need to somehow take on board. So I am doing a PhD looking at how we can integrate chiropractic into primary healthcare systems in the UK, in the NHS. It's not the best picture, I'm afraid, but there you can see this is in an NHS clinic, and you've got the rare sight of chiropractor on there. So I'd never seen that before in an NHS clinic, so I had to take that a picture of that. And this is the clinic that I'm going to be doing a service delivery evaluation on, seeing what the GPs think of this, what the physios think of it, what the chiropractors think of it, what the chiropractors in and outside, so the chiropractors in this clinic, and just the chiropractic as a profession thinks about it. I don't know, I mean, this is probably speaking to the converted here, but a lot of people don't want to see this within the chiropractic profession. They don't want to see chiropractic within the NHS. So it'll be an interesting thing to take on board. Will it dilute what a chiropractor can do? Will it affect our identity? Will it blur the identity so much that maybe we're not sure how we're differentiated from physiotherapists? So I can understand why there's some caution towards this, but ultimately that's what my project's going to be about. And I'm currently doing a systematic review looking at how chiropractic is integrated into primary healthcare systems around the world, and seeing what we can learn from that and maybe how we can benefit from that. So that's me, and ultimately that's why I'm here. But my real interest is in physical activity. That's my bias. All the views from now on are my own personal views. I do a little bit of work for the NHS and University of Southampton, University of South Wales. Hopefully they have similar views to this, but as a kind of a warning, these are all my views from this point forward. So active self-management is one of those things that I say is like the new kale or the new goji berries, or whatever the latest trend may be, because everybody seems to be talking about it. It's almost like the biopsychosocial model of healthcare. Everybody's talking about it. I don't really see what it is, though, or how it's being delivered. And I think it's a good question to ask, what the hell is it? Because self-management is in every single major guideline that you'll ever see. It's in the NICE guidelines, it's in the Lancet, it's in the National Low Back Pain Pathway developed by Professor Greenock. The American and British Pain Societies talk about self-management. So it seems to be a really important thing. And with that in mind, I kind of wonder how important is it really, because, so I'll come back to that slide, but how important is it really? Because is it a significant part of the chiropractic education in the UK? It wasn't something that I knew much about. I've got a little bit more awareness as to what goes on in the other colleges now, and there's little bits that are being introduced. But I really don't feel that we have enough of self-management strategies or self-management awareness in our education. The British Pain Society are highly critical of self-management and pain education in general within all the healthcare professions in the UK. In fact, the British Pain Society suggests that the vets get the best pain and self-management education, which is quite ironic, really. And just going back to this slide, so this is Fiona Blith and Michael Nicholas. So there's been quite a few reviews on self-management, but the reality is it's probably quite hard to teach because there's no real clear definition. Whenever you're trying to define something, you'll go into the research and figure out, well, what is this? What is pain self-management? What is active self-management? But whenever you look through the research, you realize, well, nobody's clearly defined this yet. We don't really know what it actually is. This was a really cool paper that came out at the end of last year. I've contacted this guy 3 times, the first author there. Owis, I'm quite comfortable with Owis. I have no idea how to pronounce his surname. I say Ilian. If anybody knows him, please let me know how to pronounce his name, because I've emailed him 3 times and I've said, I really like your paper. I talk about it on presentations, but I don't know how to pronounce your surname. Can you tell me how to pronounce your surname? And he's ignored me 3 times, so maybe he thinks I'm some sort of research stalker or something like that. But this is an interesting paper, quite relevant to us, because it's about what the chiropractic interns, as they call them, or chiropractic final year clinic students, as we might call them here, what do they feel about self-management? What's their kind of ideas towards it? Is it something that's important? But also looking at the clinic supervisors themselves, did they feel it was a useful thing? And they generally both said the same thing. They both said that, yeah, we feel it's important, but we don't really get much training in self-management. We would benefit ourselves and our patients if we had a bit more training in self-management. They both said that the biggest barrier was a lack of time. They said that we probably don't have enough time to introduce any sort of self-management routines or strategies into what we're doing at the minute. And if we look a little bit deeper into what the interns actually said, the interns, I kind of feel a little bit sad every time I read this, but the interns said that if they focused on self-management, they felt they would lose patients. They wouldn't have enough time to do what would be effective self-management. And really interesting, and I've spoken with David Byfield about this, is that we know in final year it's quite intense when you're in clinic. You've got so many targets to reach and you're doing your thesis at the same time. So the students really always, whether we like it or not, will always push towards what is on the curriculum that they're being assessed on, what they have an exam on. That's where they'll put their priority into learning, and probably rightfully so. So they say that because there is no real integral program on self-management, it's not something that's assessed, it's not something that there's an exam on, then why really should I bother learning it? So because it's not a core program requirement yet, they're not going to invest much time in learning it. The interns generally said that the supervisors generally said they wanted more information on the topic, which was the same as a lot of healthcare professionals. But I did want to pick out one. One clinician said he was terrified of the idea of having self-management taught within the chiropractic education, which I felt was quite interesting. He actually said it would destroy the ability of a student to produce clinical reasoning. So ultimately, that's what these qualitative papers are for, that we get these attitudes and beliefs and we find out what people think. I wouldn't necessarily agree with that, but ultimately his opinion is worthwhile as my own. This was a opinion piece. This lady, Arwen, again, I'm not sure of the pronunciation of her surname, Patizer, she does a lot of psychological research on the importance of time management. And she kind of suggests that we don't place enough value on time and that the healthcare systems need to shift their model. The simple fact of giving a patient an extra minute or an extra few minutes, that in itself has got strong therapeutic value, as opposed to trying to force consultations or fit people into a package. Now, sometimes when I talk about this, people's eyes glaze over because, okay, I don't have the time, I've got a business to run, there's no way I can fit this into the model I'm currently working with, and I'm not suggesting anybody does that. I'm simply showing this research that suggests that if all healthcare professions offered a bit more time with people, I think it was David Byfield was talking about this yesterday, then therapeutic outcomes could increase. Now that may sound obvious, it may sound impossible, but I think it's something that we should perhaps consider, and I'll discuss why in a moment. Another thing that's interesting is this paper talking about productivity goals in rehabilitation. And this is really whenever people are set targets. So if you go and work in a new clinic and you're told, I need to see 30 patients a week or 40 patients a week, or even if you're in a clinical year at college and you're told, I need to do 4 reports this week, or I need to see 5 new patients this week. The suggestion is it's not high, it generally doesn't happen that often, but the more productivity pressure and goals that are put onto the clinician or the student tends to lead to higher unethical practices, so less evidence-based practice. So when we're putting these time pressures on clinicians, there seems to be a little bit of a problem. So going back to the overall body of research, there is no consistent support for any specific self-management strategy. That's probably not a big surprise now that we understand a bit more about this biopsychosocial model and package of healthcare. And it should be individualized and specific to the patient in front of you. So it's probably going to be impossible to ever find a cookbook approach of a self-management strategy that works for every single human being. At this point, I should probably say that my bias is very much towards self-management strategies. I've already mentioned an app I've created on self-management, but being a good researcher that I've tried to be, it's important to look at the whole body of literature, including some negative literature around self-management. And there's actually a significant amount of self-management reviews that don't really show any spectacular results. This was an interesting one by Oliveira in 2012, and he challenged the idea of self-management in all of these guidelines, because he basically said that compared to nothing, self-management seems to be okay, but whenever you compare it to anything else, any other form of treatment, there's no superiority, there's no improvement in any sort of outcome. But this is why it's useful to actually read the papers and read the methodology and figure out what's actually going on in the paper, because when you dig into this particular paper a little bit, you'll see that their self-management strategies, there was massive heterogeneity amongst what self-management was meant to be. Often in this case, they were given patients a leaflet. Again, this came up in one of the talks yesterday. So they were giving them a leaflet, and that was actually being compared against people going to exercise classes, like somebody perhaps going to a yoga class. And because this person going to the yoga class may have done better than the person being given the leaflet, then this was suggested that self-management perhaps wasn't that useful. I don't personally see why yoga cannot be part of a self-management strategy for an individual. So the purpose is what's being suggested as self-management strategies within research is probably not a very effective self-management strategy. And that's why we possibly get these kind of results on larger reviews. This was a gentleman called Nost, a Norwegian guy, and he compared a self-management strategy, which sounds okay. There was a group of people talking about pain management and self-management strategies, nutritional, behavioral changes. They did it for a period of 6 weeks, and they used a control group of another group of people who were outside exercising. And again, I don't think that's a fair control group, because what actually happened with the group that were outside exercising was that they enjoyed what they were doing, and then they actually asked for the exercise activity to be moved in one area of the park to another area that was close to a cafe. So after they did their exercise, they went into the cafe and they all chatted about their pain stories and what was helping them, which was exactly what they were trying to get the group who were doing the self-management stuff to do. So this was after 3 months, so short term, and fair play to Nost. He didn't give in. He went for 12 months, so he kept going, and he went for 12 months and he had the same thing. There was no difference between the two groups, which I wouldn't expect. And again, a bit more recent, Mansell's paper, again, he suggests that the evidence isn't really that strong for self-management, and there's massive heterogeneity amongst what it should be. And this it's a bit blurry, but that's the forest plot. So you can see that not many of them crossed over the midline, and even the ones that did, this is for pain, there was only a difference of about 1 or 2 on a pain scale, and you had similar results for the disability as well. So this is a critical interpretive synthesis paper, which is a form of qualitative research. Has anyone ever heard of CIS? It's a real mind bleep. So I think Elizabeth, brought up the idea of the pyramid where you get systematic reviews and randomized controlled trials all the way down to expert opinion. What critical interpretive synthesis does is it flips that on its side. So everything I thought I learned about research, I went to a critical interpretive synthesis lecture and realized, well, there's a bit more to this. And you know, you may not be a fan of qualitative research, but I think it's important in terms of pain management. Pain is so complex and so biopsychosocial. I think all the quantitative papers trying to put a definitive measurement of pain is a bit of a problem, and perhaps why we haven't really got to the bottom of the problem. Whereas the interesting papers for me, my own personal opinion, is these kind of qualitative papers when we're looking at the patient's beliefs and attitudes and fears and opinions. I think I've probably found more valuable information from these papers. Critical interpretive synthesis actually allows blogs, it allows expert opinion, and it values those in terms of creating insight as a level playing field as something like a systematic review. So a bit controversial, but that's what a CIS is. But this was just talking about the idea, and self-management's got to go way beyond just disease modification or managing the person's pain. It's going to look at their functional goals. What patients have said is that they want help or they want support in all areas of their life, not just kind of managing their own pain. And this paper from Ferreira back a few years now suggests less pain isn't always the goal whenever people come and see clinicians like us, which kind of sounds surprising. It might be different to what you may expect, and I'm not saying that pain management is not important. It is clearly very important, But this actually suggested that pain intensity was not the #1 reason why somebody would see a manual therapist or a physical therapist. It was more related to disability or unable to do some of the functional goals that they wish to do. So in terms of self-management, some of the things that we do know for sure is that the patient is expected to play an active role in their own management. That's we probably would have known all of that. And they identify their own personal treatment goals, and they collaborate with you to figure out ways to achieve them. The strongest evidence seems to be in multidisciplinary programs. However, there's a bit of a question mark in that, and if I get time at the end, I will challenge that a little bit, because I'm not sure I fully agree with that statement. But it's not that I don't believe in structured multidisciplinary programs being the best way to deal with self-management and chronic pain issues. There just seems to be a bit of an issue with the patient seeing so many different practitioners and building up that relationship with so many different practitioners. So is there a role for a profession to be expert enough in all of these kind of biopsychosocial realms that could perhaps treat 90% of the chronic back pain that we see? I would argue that yes, there is a profession that can do that, and that's the vets. No, it's the chiros. So I think self-management is a little bit of a misnomer. I think people don't really understand what it is and what it should be. There's a hell of a lot of people out there, by the way, in lots of pain who are already self-management. These are people you will not see. They're getting on with their life and they're doing things quite well. But there's a hell of a lot of people out there that really need some help and support, and they need ongoing help and support. And the research supports this. This is a commentary from the British Medical Journal, and it was looking at older people and the kind of push to get older people to self-manage. And what they were suggesting was that there was this kind of stigma, if you like, against overemphasizing people's need to be independent. I mean, that's very different to what we may have heard before and what I've certainly heard before. But it was suggesting that, you know, some people simply do need ongoing support and ongoing help, and that when you push them hard to be independent, then you're going to create a major problem. You're going to create a problem with their confidence. You're going to create a problem with the partnership they have with the clinician. And it's not just older people, people in harder to reach groups. And the people in this paper, harder to reach groups, was people with low-level mental health conditions, people who lived in rural areas, generally people who they're hard to kind of get them to interact with healthcare. They're very hard to get them to interact with research. They're people that we really want to know a lot more about. But when they did a qualitative study, this is Joe Adams' paper, we realized that what these people were saying was that they didn't like the self-management. They thought they weren't being listened to, they thought they weren't being validated, and in general, they didn't feel they were being given much help or support. So I think we're doing a pretty poor job in terms of self-management at the moment. So this was a paper by Hutting in the beginning of this year. And these are some of the things that he suggests that we should be promoting to try and develop self-management strategies. That's quite a few there. There's a kind of graphical representation of that. There's just no way, we can do that in one session. There's no way we can cover all of these bases, even I think in a few sessions, 15 minutes. There's a lot to take in, there's a lot to address, and I think we've got to maybe reconsider our strategies on time management and how we can go about kind of addressing some of these issues. But if there's one thing to take away from the presentation today, and if there's one thing I'd like you to wake up for, it's this idea that, ironically, self-management is a partnership. So there's a doctor, a professor actually called Yu Fu, who works at the University of Leeds. She's a psychologist, and she says it in a lot of her work and in her most recent work that the patient-professional partnership is key to the success of self-management. I've spoke to Dr. Yu Fu quite a lot. She goes by the name of Maggie, which is really helpful because one of her closest colleagues who also does a lot of self-management research is, believe it or not, called Gu Fu. So you've got Gu Fu and Yu Fu, and it's quite difficult when you're trying to collaborate and talk with them. So she goes by Maggie, which makes life a lot easier. And this is not a new concept, this idea of the partnership. So the work of Julie Barlow and Kate Lorig and Marianne Matthias, these are big players, if you like, in the world of self-management. They've produced textbooks and multiple papers. they all bring up this idea that if you want self-management to work, the most important ingredient is the partnership with the healthcare professional. And quite simply, that partnership means that everything that you do, everything that you suggest, the compliance and adherence to those interventions will go up. There's people here know about Peter O'Sullivan. Is he a well-known name? So Peter O'Sullivan is a very well-known low back pain researcher, chronic pain researcher. He's developed a system, if you want for a better word, called cognitive functional therapy, CFT. It's had quite a big influence on the way I work. I was a big Peter O'Sullivan fan for many years, and despite this story, I still am. So I went to his cognitive functional therapy workshop, which has a lot of self-management ideas on there. And one thing he kept saying again and again and again was, you need to ask the patient, what's their story? Pretty much the first thing you should ask them is, what's your story? And then you shut up. You don't say anything. You use a style of motivational interviewing where you let them express themselves and tell their story. And he said this so many times over the weekend that it completely stuck in my head. So I couldn't wait on Monday morning. I had a patient in, a new patient. I thought, I can't wait to ask this lady what her story is. And I'm so excited about this, as we tend to be when we come back from CPDs and things like that. So this lady walked in on Monday morning and she was kind of quite cold towards me. She was in a lot of pain. She didn't give me any eye contact. Everything I kind of understood about an individualized approach to treatment, everything I'd learned up to that point in my life, I threw out the window because that wasn't important anymore. I wanted to ask this lady what her story was. Didn't really care about anything else because Peter O'Sullivan said so. That's what you should do, and you should shut up. Am I allowed to swear, by the way? Because if I give an accurate account of this story, there's a swear word in it. So the lady walked in, and pretty much before she sat down, I said, "What's your story? What's your story?" And she looked at me. She's like, you know, eyes almost popped out of her head, and then she kind of sunk back into her seat. But Peter O'Sullivan said, "Shut up and let them speak. And even if there's a bit of silence, just wait for it." So I waited, and I waited, and I waited, and I had the most excruciating 5 minutes of my life where this lady was wriggling in her chair, and Peter O'Sullivan said, "Don't say anything, don't say anything," someone who I admired very much. And eventually, after 5 minutes, the worst 5 minutes of my life, she looked up at me and said, "What the fuck do you mean, what's my story?" And getting any therapeutic alliance back from that point was very, very difficult. But it kind of reminded me, I mean, I still use the question, "What's your story?" a lot. It's a very appropriate and useful question to ask to get information. But you know, everything is an individualized approach to that person walking through the door. And at that time, for that patient, for me, it was just clearly the wrong thing to do. And I should have known that. So with self-management, one of the most important steps, 5 past 10, okay, going to speed up a little bit. So one of the most important steps is building effective communication and when it comes to self-management. So we know, again, in a lot of the qualitative research that patients who come in and see people, especially with things like back pain and chronic pain, they don't feel validated with their pain and they don't feel listened to. And when a patient doesn't feel validated or listened to, then that's a big problem in terms of building that partnership with the clinician. Managing expectations is a big problem. We know from a lot of research that expectations are actually one of the biggest predictors of outcomes. So if a patient expects to feel well or expects to feel good after a treatment, their chances of that happening will occur, and the same if they don't expect much help. So managing expectations is really important. And there's this kind of shift towards what matters to you as opposed to the question that we always asked before is what's the matter with you. So lots of research suggesting this question. That's actually the first question on the personal health inventory, which is a PHI, which is a clinically validated questionnaire that you can send patients before you see them. And you can see there right at the very top that question, what really matters to you in your life. So quite a useful question. And I put this in. You know, you can research it if you wish, but just with this area of time, my bias is that we should just give people more time. Who was it yesterday? Alistair, I think it was talking, and he said, who is it really follows these guidelines with these long, like 60-minute activity sessions and patient education and all of these kind of things? I was desperate to be in a room at that time because that's what I do. That's what I do. I spend a lot longer with patients. It's a very, very active approach of care. Once we've got them beyond the stage of passive care, I have no problem seeing people for active care for periods of time, which I'll try and defend in a moment. But if time is a problem, then I'm trying to figure out some solutions, and the PHI might be one way of getting some very useful information before you see your patient. And Sarah Evers has got this paper on communication, especially when we're communicating about chronic pain. Showing empathy, so Jeremy Holwick's work would probably be useful. He does courses on empathy, or just record his voice and put it in your treatment room, and listening well. So patients also, they don't like this label of non-specific low back pain, which is a problem, because it seems to be that's what 90% of the cases are that we're seeing, or for low back pain patients, is a non-specific cause. We're struggling to put a specific anatomical cause to the reason why they're in pain. But patients don't like that diagnosis, so being very good at communicating and explaining the kind of sensitivity around pain, maybe pain being like an alarm signal, getting good at that is what patients seem to appreciate. And something that's often neglected, I think, is that patient self-management is really healthy for the practitioners themselves. In the US, the profession with the #1 rate of suicide is the medical doctors, and in the medical health professions, it's a bit of a problem, in general. And in the UK, I think it's health professionals twice as likely to commit suicide than someone in general population. So there's something going on with healthcare professionals, and from the little bit of work I've done and from talking with people much more experienced than me, I think naturally we're quite empathetic people. We go in generally trying to help people, but whenever we deal with people in chronic pain, I do a bit of work on the NHS where I see a lot of people with fibromyalgia every single day. It is very, very draining. And we're giving a lot of ourselves to these patients, and it is a challenge for our own mental health. What Marianne Matthias's research suggests that if we can get better at creating better self-management plans that our patients can actually stick to, then it actually has good positive results for the clinician's own mental health. So I think that's an important thing to address. The next step is we've got to get really good at empowering the patient. And quite useful, there's a lovely paper by Warbrook last year. It's like one of those idiot guides. It says how to empower patients, a systematic review. So for someone that's quite simple like me, I love a paper like this. And to really chop it down in a nutshell, it was suggesting that the really important elements to address empowering a patient was goal setting and action planning, which is really just figuring out a plan to meet these goals in the first place. Knowledge was on there, education was on there, but it was only important when that was combined with any sort of action towards the goal setting. So knowledge on its own, and this kind of mirrors some of the research that you see on therapeutic pain education on its own. It's really not that effective, but as a strategy, as part of a multimodal package of care, then it can be very, very useful in addressing things like kinesiophobia as one. This is the PHI again, so you can see it's addressing lots of elements of functional goals, so nutrition, sleep management strategies, stress management strategies. This is just an idea of all the information that you could potentially get before you even see a patient, if that's the way you work, which again just may help to address this issue of time. And the reality is that if you can make a clear, agreed treatment plan and you've got a good partnership, that accountability and compliance will generally go up. And Fu, who I've already mentioned a couple of times, she explains that these goals should not just be around pain management, it should be around functional goals. The patient, simply ask the patient, what's important to you? Maybe what is your pain stop me from doing, or what would you really like to be able to do? And that's your starting point to build some sort of graded exposure to figuring out what's useful for them and help them figure out ways to do that. When I talk about goal setting, I used to say when I talk about goal setting to chiropractors, but I've done enough CPDs now to realize that no matter who I talk to, people's eyes glaze over a bit when it comes to goal setting, because it just seems such common sense. It seems to be something that we should all know about. The reality is, in practice, we're probably not doing it that well. So Kent Stuber, who's a Canadian PhD, who I've been lucky to have a bit of contact with. He's doing really interesting work, and one of the pieces of work he's doing, he's looking at something called the PASIC, Patient Assessment of Chronic Illness Care, which is actually a system, if you like. It's a questionnaire, but there's a little bit more to it, where it's an assessment of patient-centered care. How well is this person delivering patient-centered care? And the good news is that the chiropractors are actually doing quite well. When you look at the scores across the board, comparing them with other healthcare professions, the patient-centered care of a chiropractor was actually quite high. Where chiropractors were let down was on goal setting. In fact, in the interview data and comments like this, no, I've never actually actively done any goal setting, were actually more common than I would have liked to have seen. So chiropractors probably would have been top of the table had they have had their goal setting in order, if you like. So this piece of research, it wasn't massive and it was only limited to Canada, but was suggesting that we can get a lot better in our goal setting practice within clinic. Again, trying to address the idea of time. Just to repeat, my bias is just to give a bit more time, but that may not be financially feasible or just work in with your business model. But there is a quantified intervention called brief action planning, BAPs, which lasts about 10 to 15 minutes, which is a style of motivational interviewing. It's pretty simple. It's very easy to teach. I'm not sure if it's in all the educational institutions. I wouldn't be surprised if it's in some now. But again, just another way you can kind of address the idea of goal setting, which we know that if BAPs are introduced, then self-management outcomes tend to increase. And Tanya Gardner actually came up with this paper earlier in the year, and it was combining patient-led goal setting with a little bit of education. And the results were actually really impressive. This is a worthwhile paper to dig into because the results were maintained over a period of 12 months. It wasn't massive enough in terms of a systematic review, but what it was showing was differences in 3 to 4 on a pain scale of 10 that were maintained over a period of a year. Same with some kinesiophobia and other secondary outcomes they looked at. Now, if we had that result with spinal manipulation, someone would be doing the presentation right now and I'd be drinking coffee upstairs because that would probably be more interesting and more important for us. But simply doing goal setting, combining it with a bit of education, really give quite significantly impressive results. I would like to see bigger data on this. But yeah, really interesting thing that perhaps we need to give a bit more priority and emphasis to. Communication was a big issue yesterday with what Jeremy Holwick spoke about. Another researcher on a similar vein is a gentleman called Ben Darlow, who's got a lot of research on communication, especially clinician communication and nocebo, which was mentioned yesterday. And simply what we say, our words as clinicians are so important. They have such a large effect on patients. So our own beliefs, our own structural beliefs, what we think about posture, what we think about core stability, what we say to our patients that your pelvis is out, your atlas is upside down or out to the right or out to the left, the kind of things I was told, that might not be the best plan of management for a lot of people. In fact, it could actually lead to problematic outcomes. So we need to not just educate our patients, but really educate ourselves and continually educate ourselves, because ultimately we're only ever becoming a little bit less wrong about things. Paper by Menendez suggests that the most effective pain reliever itself was self-efficacy. So the sense that one can manage themselves and everything will be okay. So doing something to create a patient who's got an increased self-efficacy seems to be the strongest pain reliever we can do, way ahead of any sort of intervention, manual therapy, exercise, my own bias. So anything we can do to improve self-efficacy is going to be a good thing. It's not easy though, and here's some things that from a variety of research papers seem to be useful. We can do something simple like provide positive feedback. So I've got a little puppy recently, and I know that when it does things I don't want it to do, when I offer it a treat, when it does something positive, it generally responds better to that as opposed to when it pisses on my floor and I think about rubbing its head into. I don't do that anymore. My dad used to do that. He told me that's what you did. But looking at the research, I'm not sure that kind of negative enforcement is the right thing to do. We don't spend much time with our patients compared to significant others. So I think it's important to kind of figure a way that we can involve them in the role, compared to the time we have, compared to the time they have. It's really non-comparable. So to really address self-efficacy, we need to somehow figure out ways to get them involved. We all know about SMART goals, so again, goal setting comes up again. Maybe the idea of building a self-management toolkit. So the more we understand about chronic pain, we know it's inevitable that they will have some sort of flare-up over time. So have they got the education around that, and have they got strategies to manage it for themselves when that happens? And then also creating and utilizing multiple opportunities. I was glad to hear the making every contact count. It's a big push in NHS at the minute. I've had to do some courses on it quite recently. So it was nice to hear that discussed yesterday in terms of what chiropractors can do. But what we do in our company at Back to Roots is that we try and create these opportunities ourselves, and I don't see why more people don't do this. I live in Wales now, so we've got a touch rugby club, we've got a five-a-side football club, we do movement classes, we've got a yoga class, we create workshops every month. And it's pretty simple to do, and we tell our patients about these, and they're very well attended, and they tell other people. So, making every contact count is great for me, because I just tell them, okay, do you know that we're doing this at the end of the month? So more business, if you like, for us, but I can be ethical with that and think I'm doing quite a good thing. And again, this paper, I don't want to rush through the papers too much, but I'm running out of time. But this paper was suggesting that self-efficacy, as you probably would imagine, will increase compliance and adherence to any sort of self-exercise program that you have. This is an idea about that toolbox I was talking about. So some things that we can discuss with our patients: pacing, graded exposure, goal setting we've already spoke about, just simply knowledge and exercise. And yes, manual therapy is on there. Manual therapy is a very useful way to calm the system down, so it can certainly be a useful part of your package of care. However, I don't think it should be the only part of your package of care. We know that people who just rely on passive outcomes often long-term don't do so well. So introducing some sort of active coping strategies, some sort of active component to your treatment generally seems to lead to better outcomes long-term. Predictors of self-management for chronic low back pain. I've put this paper in, Jennifer Cowie, because one of the biggest predictors of self-management, surprise, surprise, was the support and the partnership between the clinicians. So it keeps coming up again and again and again. Do not underestimate the relationship you have with your patients and how big of a driver that is for any sort of adherence or compliance to anything that you want to get them to do. And here's where I might get a bit controversial, and this is my own opinion from my own interpretation of the research. So I think that this partnership, which is really important for self-management, can be ongoing, and it can also lead to continuous care. As long as that continuous care is active and active in nature. Patients actually have suggested that they want, even the patients that have done well with their chronic pain management, had really good outcomes, have still said, I still want some access to my healthcare provider. I still want some sort of support from my healthcare provider. And what was shown was that when that relationship remains open, it's not patient vulnerability or patient reliance on the practitioner, but they actually self-manage more. They're more likely to self-manage. They're more likely to exercise on their own. They're more likely to do their stress management techniques on their own. They're more likely to eat the extra portion of vegetables, whatever it is that's being done, when they have got that relationship open with the healthcare professional. So I think there's a lot of people that we should have continual care with as long as we are providing the less wrong information. This does not mean having them on a couch 3 times a week for a year. It's providing and helping them do behaviors that are going to be beneficial for their health. This was a little bit what I mentioned earlier, the middle paragraph there. Patients have also said in the qualitative literature that they don't like seeing multiple practitioners and having to repeat the same story, the same history all the time. Is it possible to have a single clinician that can talk about exercise, can talk about stress management, that can talk about nutrition, that can provide manual therapy, that can do all of the tools without them having to go and see multiple people for that, and also have that good, strong partnership and relationship with them? I think that is possible. This is a gentleman called Do. These are the key elements, core components if we want to create self-management. So these two kind of go together, problem solving and decision making. What we do in our clinic is we create environments. So if a patient says they have problems picking things up off the floor, for example, we may create a game or some sort of creative application where we add some graded exposure, whether they're catching a stick or picking something up. We'll try and make it as fun as possible. But what we're doing there is implying elements of non-linear pedagogy and dynamic systems theory, where basically the patient is solving the problem themselves. They're working out ways to move their body to actually figure out the problem. They can flex forward. They might need to move with a bit more variability. We know movement variability is a problem with people in chronic pain. What resources they have available. So it's a big barrier to people trying to get them to be active if they don't have available resources. So we're going to have to figure that into our management. And it comes up again. Another paper, the clinic-patient partnership is absolutely key. Goal setting comes up again. And making it individualized, making it important and relevant and meaningful for the patient. That's my very good friend and colleague Luke Davis there in one of our workshops. And the final step, if you know me at all, you know my biggest bias is playing and playing around. And I mean that quite ambiguously. I think research is simply playing. I think we're just experimenting with different environments and situations and playing around really and seeing what happens. And I think with this uncertain evidence base around chronic pain, we have got no option but to play around and to try and experiment a little bit and tease and nudge the edges and figure out how we can do to kind of increase someone's capacity in a way that's meaningful for them. Well, have I got 5 minutes, Lawrence?
No, you've got a bit more. Just waiting on the coffee, so I'll give you a nod.
All right, cool. I was like panicking there a little bit. The breathing was going up. So exercise. Self-management, by the way, is a hell of a lot more than just exercise, but exercise really is at the crux of a lot of self-management programs, trying to figure out how to get people more active. Ben Cormack, who's a friend of mine, he's got some very good courses where he talks about adherence and compliance to physical activity, and he asks a very good question: what is the external validity of exercise? So we've heard a lot of good things about exercise this weekend, about how it can be very good for preventive health, how it's very good as a treatment for many health conditions. The external validity of exercise is shockingly low. So what that means is that exercise works very well when it's done, when people actually do it. But the reality is most people don't do it. And we've been talking about getting people more physically active for decades, centuries, but just telling people to exercise isn't enough. It doesn't seem to be enough to get them to change their behavior. This was the European back pain guidelines with Chris Mayer's group that came out at the end of last year. Put this in because this is suggesting that it doesn't really matter what type of exercise it is that you do for patients. So whether you want to do core stability work or weight training or gymnastics or anything, nothing has been shown to be superior than anything else in terms of physical activity. What's important is that the patient does it and they enjoy it and they will be able to do it consistently. Interestingly, and I like this, it says that it's not just patient preferences that should be influencing this, but practitioner preferences also can be a valuable influence on what the patient does in terms of physical activity. And that kind of made me laugh a little bit, because how active do you think physical therapists are, chiropractors are, health professionals are in general? Are we that active? Are we inspiring people to move? Are we like saying, okay, I'm going to tell you need to do more exercise, and they look at you and you maybe haven't exercised yourself for 30 years, who knows? So when we dig into the research on this, physiotherapists, if anybody is going to be physically active and know the physical activity guidelines, surely it's the physiotherapists. They were in the UK, less than 40% knew the physical activity guidelines. I actually had it emailed to me today. The exercise physiologists So this is not on this presentation. If anyone emails me, I can get it to you. I just had it sent to me this morning. Exercise physiologists in Australia, 18%. The Australian physical activity guidelines and our own guidelines are pretty much the same. 18% of that makes no sense to me. How can only 18% of exercise physiologists know what the physical activity guidelines are? It's the same across a lot of physical activity. It's the same across a lot of healthcare professionals. Even the psychiatrists in Australia and New Zealand, they were down at about 30% knew the physical activity guidelines, and less than that were active themselves. And GPs. So this was in the Medical Journal again of Australia, but it was suggesting that GPs don't get enough physical activity or exercise education within their curriculum, therefore they didn't feel confident in prescribing it. And another big factor was that the doctors that were not active, which was most of them, didn't actually prescribe physical activity very much compared to a doctor that was active. So the more active the clinician, the more likely they are to prescribe and influence on physical activity. So perhaps we really need to get our own house in order, and if we're really going to inspire or tell people that they should be doing certain behaviours. And again, I think it comes a little bit to what Catherine says, that the way we deliver the message is really important. Exercise adherence, there's a lot of papers on this. This is Reina's paper. It suggests 50% or more were not complying, and that's actually quite generous. There was a lot of papers that were suggesting even down to about 20%. So a physiotherapist or chiropractor, when they prescribe an exercise program, do the patients do it? Generally, no, they don't do the exercises that we give them. The same with self-management. When you give somebody a leaflet, that doesn't seem to be very good in terms of changing their behavior. And as I said, the World Health Organization last year said that physical inactivity is a pandemic, and that just telling people to do exercise, and we've known this for hundreds of years, telling people to stop smoking, telling people to eat less, just doing that is not enough. We need to be a bit more creative with our strategies at getting people to change their behavior. So how can we help? Well, this is a lady called Sanne Angel. She's at a Danish university. I think she's Norwegian, but she might be Danish. But her name is Sanne Angel. I love this paper because she said, apart from the things at the top there, which you can read, the biggest driver to get people to comply to exercise and physical activity was meaning, joy, and passion. So was it meaningful for them, and did they enjoy it, and were they passionate about it? That was it. That was so far ahead of anything else. We have to find things that our patients enjoy doing. And we can ask them, what's meaningful for you? And they might not even know what they enjoy doing. We introduce all sorts of physical activity into our programs with people, gymnastics, boxing, skipping, whatever. Often, I've yet, this is my own bias, I've yet to meet one person that does not enjoy some sort of movement in some way. Now, I love dancing, but I'm not going to dance right now because I'm too embarrassed to do that in front of you. If I had Luke up here, he would dance for you. But the point is, I need to feel safe and comfortable in an environment. So we've got to make our patients feel safe and comfortable in an environment, because we're always pushing them and challenging them to go out of their comfort zone a little bit. So giving them new ideas, they may like it, they may not, but I've yet to meet somebody in 20 years that doesn't enjoy doing something. I did have one guy actually, a chief executive of a very large insurance company, a multinational insurance company in London, and I was teaching him like some sort of pelvic movements, pelvic tilts, and he said, I'm not doing that, Paul, I'm not doing that nonsense, blah, blah, blah. And he was a very rich man, I used to train him in his home. But I remember telling them and saying it may be useful, it may loosen up your hip a little bit. But he said, I'm not doing that, I just want to do a bench press all the time, which is what we generally did, kept him happy. But I remember going up to his home one time and knocking on the door, and his wife let me in, and he said, yeah, he's down the gym, go down to the gym and see him. And I went down to the gym, and he had this music blasting, so he couldn't hear me coming, and he was standing in front of the mirror, and he was doing all these like pelvic tilts and stuff, and all these kind of moves that we had spoken about. And it made me so happy that he wasn't comfortable enough to do that in front of me. And I didn't let him know I was there. I actually went back and came down 10 minutes later. But, clearly he was being influenced in some way, and he felt safe doing it on his own. And that was happy. I was more than happy with that he was still doing it. So we've got to find ways to make our patients enjoy it. And I think that also ties in with the patient-professional partnership. I think the two can go very nicely together. Some examples of some of the education slides that we've used. You can get a lot of these from Adrian Lowe, although he doesn't like you using them, so you have to ask him for his permission, which we have asked. So just showing that tissue healing and pain aren't always the same. Often pain goes on long beyond tissue healing times. Sometimes we can explain the storytelling narrative that pain can be like an alarm, like a sensitive nervous system. So like those old car alarms that I had back in the early 90s, a little fly would fly past and the alarm would go off. It wasn't necessarily saying there was a problem with the car, but the alarm was a little bit overly sensitive, and we have already spoke about tools where you can calm the system down a little bit. Difference between acute and chronic stress, how it can affect your pain, how it can also affect your response to physical activity. And really what we're trying to do is get closer towards those meaningful tasks that our patients want to do, and that's always going to be a nudging approach. If we don't give too much, then there's not going to be really any adaptation to what we want them to do. If we give too much, then we're creating that boom and bust cycle where they're more likely to have some sort of flare-up. So we're always touching, teasing it, nudging it, ultimately with the goal of trying to expand their envelope of function, getting them to do the meaningful activities that they wish to do again. And I was really surprised and interested that this came up yesterday with Alistair, I think it was, brought this up. Is this the answer? Is this the answer to our prayers? The GLAD back trial by Jan Hartverson's group and Per Kerr, I think is how you pronounce it, who's the prime author. So I really respect people that try to show what they're doing or trying to create a solution to the problem. It's very easy to say all these problems. There's not many people actually providing many solutions. Peter O'Sullivan with the CFTs, maybe one idea, and Jan Hartverson's another one that seems to be doing something. Because we hear a lot of people talking about it. Someone said to me the other day, it's like teenagers talking about sex. They're all talking about it, but nobody's actually doing it in a way. So this was the GLAD back trial. They were trying to really give an evidence-informed package of care for people with low back pain. As Alistair said yesterday, they had 2 sessions of patient education where they covered these kind of areas. They were talking about the back being strong, bad postures and things like that. Maybe not necessarily bad. In fact, they're fairly common. Pain's more like an alarm. It doesn't always equal harm. They were talking about pain in general was almost like a balance. If you've got too many stressors and all these kind of things coming in, you're perhaps more likely to be in pain, and how we kind of balance this. So the patients were educated on this for a couple of sessions, and then they were given 12 weeks of physical activity program. And this was my favorite part of the GLAD paper, where they give these were coaching instructions. So if you wanted to deliver the GLAD, this is something I don't like about it, by the way. If you wanted to deliver the GLAD package, you need to go on a course and you need to become GLAD certified. I'm a big Jan Hartverson fan, but I think that's nonsense. I don't think we need to be going on certifications to learn how to do this kind of stuff. I think it's a bit too exclusive and almost elitist in a way. There's nothing in here that we shouldn't be able to create ourselves. But what I really did like was that the patient is not instructed in one correct way to exercise. The patient was instructed to find their own ways of doing the exercise. There was no right or wrong. So I really liked that. And then I got to this part of the paper, and these were the exercises that are in the GLAD trial. And when I look at that, they're okay. I just wonder how relevant and meaningful and individualized that they are. I respect that these were the coaching instructions, which are brilliant. But this is still a bit too cookbook for me. Now, don't get me wrong, I really respect and I love this research, and it's probably one of the best papers in terms of what we should be doing. I just still think we can do a hell of a lot better. I still think that this is a little bit too, it's a bit boring, and it's a little bit too specific despite what those coaching instructions are. So I think as good as this is, we can probably do a little bit better. Peter Stillwell is a chiropractor in America. He does a lot of work with Catherine Harmon. He is one of my favorite researchers. Well, he's an amazing paper came out this year talking about pain as an emergent process, actually pushing it beyond this kind of biopsychosocial model. One of the best papers I've read in a long time. But he's actually already done all the work for us. So I could have saved you an hour and just showed you this slide, which is exercise prescription for chiropractors. this is what we need to do, and this will increase the success of a patient actually adhering to your exercise. So all these things we spoke about in terms of providing education, pushing them from passive care eventually into active care. The two underlined, I think, are important though. So it talks about a chiropractor should confront the maladaptive passive care expectations and gradually transition into active care. Now, I recognize that's going to be a challenge for some people, but the reality is if we want people to exercise more, then we need to give them a bit more information and education about why we're doing that. And I get a lot of resistance on social media. I get resistance from when I try and defend chiropractors from all sorts of skeptics, or cynics I would call them rather than skeptics. And then I also get a lot of grief from the chiropractors who are telling me, oh, exercise isn't a part of what we do, it's blah, blah, blah. It's not like encouraging exercise is new for chiropractors. This is BJ's lab. And this is quite similar to our own clinic. I love this. He's got Swedish stall bars in there, which are quite hard to find these days. So exercise prescription has been going on since the beginning of chiropractic, really. Founded for the restoration of health to those for whom medical treatment of ordinary chiropractic adjustment and care have proved insufficient. So I think exercise is a massive part of what chiropractors do, what we should be prescribing, a part of our active care. I don't think there's any identity problems with having exercise and physical activity as a part of what we do. And this was also mentioned just today. It's not like patient-centered care, this biopsychosocial model or holistic care is new either. This is what we've been talking about as chiropractors, again, since the birth, and it's been mentioned in many, many research sources. And if we just got that goal setting up a little bit, then our patient assessment, our patient-centered assessment would probably be at the top of the tree. These are videos. I just wanted to show some of the stuff that we do in our clinic, but I can't play these. I can send them to you, but it's just playful ways of getting people to address certain fearful movements. The lady on the visual left, she was told that she couldn't flex her spine. For about 3 months, every time she moved, she'd be moving with zero movement in her spine. We educated her. We didn't do anything magic. We just followed evidence-based informed guidelines, took her through, built up a good partnership, started with graded exposure, maybe to pelvic tilts, into quadruped position, gradually into weighted Jefferson curls. So that wasn't what we did at the very start, but able to load her spine safely, strong, stable spine. And that's my colleague, Luke Davis, just playing a stick game with an old military gentleman who had very rigid beliefs. So there's a couple of interesting stories there, but that's for another day. And these are some of our patients who are writing out their own exercise programs. They've been taught to do this. They know how to progress or regress their exercise programs based on their own symptoms, based on the level of exercise that they're doing, based on the meaning of the exercise for them. So self-management going on. They still have a relationship with us, but they're actually doing more on their own because of the support that they've had. And you won't be able to read this, but this is the kind of homework that we give patients. This is influenced from Adrian Lowe's Why You Hurt cards, which is a series of pictures that you, almost like a bit cartoony if you like, but they show patients educating on some of the slides that we spoke about. We give them to our patients and they write up some homework for us, which actually helps to dictate what our next session will be. There's something called a Kieran O'Sullivan question that you should ask your patients at the end of a session. So if I've tried to get something across to my patient, I will say to them, so whenever you go home and you talk to your wife or your husband or your family later on today, how will you explain to them what I tried to explain to you today? And then no matter how well you've explained it, whatever, you should listen to what they say, because what they say is ultimately what they've understood and what they've heard. And I've had some interesting feedback. I thought I nailed it, and then the person says to me, oh, so you're telling me all the pain's in my head. And I'm like, shit, I've messed up again. I need to reflect and figure out how I can do that better. I believe you get these slides. Yeah, so all the references on there that you want. And if you ever want to contact me or Luke or see what we do, that's our information. Thanks very much. Yes, questions?
Thank you. Hello? Hello? Yeah, good. Thanks for a very comprehensive and insightful presentation. I'm just wondering, on the very last of your slides, point 3, it mentioned fear of pain. And I noticed that you hadn't discussed that particularly much. And it's something that I imagine is quite universal amongst all of us, but my experience with patients is that it's the fear of pain that gets in the way of self-management activities more than the pain itself. And I have to spend quite a great deal of time explaining to people that they should be able to understand the quality of the pain, whether it is what I would call good pain or bad pain. Pain that is present because of injury, tissue injury,
Yep.
or pain that is present because tissue is sore because it's healing up.
Yep.
And I'm just wondering if there's any research work done in terms of how to help people overcome the fear of pain, and how, if that aspect that I've taken on is a useful one, or if there are better things.
Yeah, so it would actually have been useful to play that video of me with that lady, because you can probably see in the background there, there's a mirror here, and that's on purpose. There's a mirror. So what we were trying to create there was something called expectancy violation. So when you say about the fear of pain being one of the biggest barriers to people actually doing the movement, that's really common. So what's the suggestion is that you need to kind of create what's called an expectancy violation, where they're in a position or a movement that they believe will cause them a problem or pain, but they're not in pain. So then you challenge them when they're in that position. So this was a lady who for many years has been told that she could not flex her spine. So it took a while to get up to this point, but she's in full flexion there, weighted.
She couldn't, or that she shouldn't?
I think she was told she couldn't.
Okay.
It may have been shouldn't, but I think she told me that this is going back a few years now. And when she walked, when she picked things up off the floor, she had very upright spine. So she would pick something off the floor like this. And from my clinical assessment, I didn't really understand why she was told that information. So depending on my partnership with that patient, I can think, okay, did I barge in and say everything you were told was rubbish up to this point? That's probably not the best